I'm here to talk about a balance between medical and midwifery models of birth and pregnancy care. But I came across great obstacles in deliberating this. And then I reflected and I thought about why this was happening and why I was receiving these obstacles in deliberating this very humongous political topic. And I think the problem is that I gave birth to my first child in medical school. In my third year, before my clinical rotation had started, so I hadn't gone into the clinical situations in the hospitals that had all been kind of textbook and discussions. And I had an amazing birth, and I got it. And I believe a good hearty story, personal story, is a good way to kind of root a talk. So I'll go very briefly into mine. It was about 10 o'clock at night, and I was about 39 and a half weeks pregnant, and I was crying because I thought I'd be pregnant forever. When my water broke. And I thought labor, from what I'd heard, it normally starts at least about 12 hours after your water breaks. So I went back to bed, and I just SMS'd my midwife, and I went back to sleep. Thinking, okay, let's see what happens. And I lay in bed, sleeping between the contractions, with my beloved next to me, in complete denial that I was in labor. This is a key point. There's a couple of key points. That's the first key point, denial of labor. And then, when I woke up suddenly, I felt like I needed to do something. I started shaking uncontrollably with each contraction, and I had that feeling that I needed of just needing to do something. And now, at the same time, my midwife SMS'd or phoned me to find out how I was doing and to come through. And that's another key point, is that feeling you need to do something. So by the time my midwife came, my baby was almost crowning, and feeling the full intensity of each painful contraction. With the descent of my baby, my midwife was able to focus me, ground me, and centered me, and so Lochan was born. And I've told the story many times, and it was 8 years ago, and I still shed a tear. And I got a few stitches and then snuggled into bed with him for the next few days. And this brought forth my major obstacle in deliberating this topic. A balance between medical and midwifery model of care. Model of birth care. Because birth is not a medical event. And birth happens even if the midwife is not there. Birth is between the mother and her baby. It is a matter of heart. I really tried. I did several rotations of obstetrics in medical school, internship, community service, in diverse hospitals, MOUs, saw private mothers, assisted private midwives, home births, spoke to many mothers, seen mothers die, seen mothers almost die, seen babies die, seen babies almost die. Labors go bad quickly. Labors go bad slowly. Caesarean sections turn bad. Life-saving procedures work and not work. The underlying incentives, attitudes, practices that people want to call models lack humanity, individuality, and truth. It always comes back to this for me. There is an unacknowledged truth about birth. It works and it empowers. So what model supports this at its core? The medical paradigm, whether it be doctors or midwives, looks through the glasses of fear. fear of risk of morbidity and mortality, or litigation. Protocols and decisions are born from this arena, which makes them feel very safe as they revolve through the doors of statistics and research reviews. But in a case when you have to do 1,100 procedures to prevent one risk, we need to take into account any risk that the procedure may have in turn and its effect on the woman's future. But we're not speaking about women. We're speaking about numbers. And this is valid and reasonable, or is it? When you're working in a busy practice or a busy hospital with high numbers and high morbidities, which you need to manage. And the midwife model is typically where the pregnant woman and her midwife have an open, trusting relationship based on mutuality, open information, shared decision-making, knowing the pregnant mother deeply, as well as her fears and hopes and characters. And still, in our reality, the midwife model that does exist is still under the banner of the medical model. My hands are tied. I have heard them say. They are tied up in a medical model. The medical model holds the power. Okay. Sitting here in your lanyard description as midwife, doula, doctor, mother, cast it off and hear with your heart. I wish to propose a sacred model of birth. What if I had to tell you that your work with mothers at this precious time of pregnancy and birth has the potential to change the innermost face, integrity, and empathy of our society? The time in the womb, the physical environment, the nutritional status, emotional and mental state, stress exposure, and connecting with your mother at this time is profoundly, deeply interconnected with your innermost character, insecurities, fears, responses. It shapes how you perceive the world. As a safe and loving place, or as a place of animosity and danger? Do you greet the world with arms of love, or with weapons of protection? Just imagine this potential. How much inter-society, interpersonal, never mind intrapersonal, with yourself, corruption, crime, psychiatric disorders, basic unhappiness can be prevented on this level? Consider how you can support this for each of your pregnant clients. Does this then not become the most important question in pregnancy care? What is your role in assisting your pregnant client to feel supported, amazing, like she is part of a huge miracle growing inside her, and she can trust her body to continue? Can you do that? Or is there some fear-based doubt holding you back? Now, just for a moment, take off your lanyard. Take off your designated hat and sit quietly and comfortably. Close your eyes if you like, and place your hand on your heart area. And remember why you are doing the work you are doing. What love, compulsion led you to do this work, which is really a calling? And just allow yourself on every level to remember that feeling. Allow it to soak over you. Feel it in each cell. Listen to it. Taste it. Embrace its color. Does it still lead you? Is it based in fear or love? Let it enter your heart again so it can always be with you as it always is. Remember this contract you have, an inner work contract, when you are consulting with each mother, pregnant or in labor, and act with this responsibility as importantly as the responsibility for safe risk prevention, control, and practices. Now, before you allow your mind to indulge you, I will assist. What if? But so many things can go wrong. What if? And the horror stories start bounding in from the mouths of all you meet. It feels like mothers, doctors, midwives. There may be so many costumes, statistics, and dramas to convince you to join their plight of fear installation. I'm not going to dwell on the specific what-ifs and fear-based research. It is glaringly obvious and logical that the medical part of pregnancy and birth is to be there to care for, correct, treat, and manage the big what-ifs. It is not to stand by and project the what-ifs before they have any sign of occurring, and to interfere to coordinate a whole new what-if program picture. There are far better and mother-centered ways to prevent risk damage. It is not to have a whole lot of inflexible protocols that can possibly act to protect the gynae from lawsuits. Because this does not put the individual mother in the center and treat her as a unique individual having her baby, as each pregnant patient indeed is. One of the best ways to avoid being sued is to have a really good, honest, and integrity-based relationship with your caregiver, your caregiver with your clients, and act soundly with rationale. The medical place is just that, it's medical. And until something is medical in pregnancy and birth, the medical place is to be on standby and support the midwifery model of care. On that note, the midwifery role is to have the skills and education to pick up any risks, prevent risks from arising, and communicate with the medical. This needs to be a balanced and in a skillful way, and as quoted from the Journal of Perinatal Education, a midwifery model of care for childbearing mothers at high risk, genuine care and caring for the genuine, allowing mutuality, trust, ongoing dialogue, enduring presence, and shared responsibility while holding the skills of theoretical, practical, intuitive, and reflective knowledge, with a special responsibility to balance the natural and medical perspectives in the care of childbearing women at high risk, especially by promoting the woman's inborn capacity to be a mother and to give birth in a natural manner. But actually, I feel that is all pretty boring and based on how we know the birth services in our public setting operates. I want to go even deeper than that, to understand from what level of ourselves we are coming to a pregnant client and how important that is. What does a woman need in her pregnancy and her birth, whether you are acting under medical or midwifery? Midwife. With women. Yes, the physical checks to exclude pathology, risks, and abnormals, while supporting and educating the healthy and nourishing physical needs to keep a healthy and risk-free. She needs to come out of a consultation with her doctor or midwife feeling terrific, amazing, courageous, hopeful. And she needs to connect with her baby. That may sound a little, well, that's very nice, but I saw a woman who was fine and then suddenly developed, or I had a lady transferred in labor and then, or I know a lady who suddenly became, but it comes down again and again to the relationship between caregiver and client. From the beginning, if you're able to spend the time getting to know your client, her fears, history, family history, stresses, concerns, character, as well as her blood pressure, and her urine, the insight you will gain to really journey with her in her pregnancy and birth will serve not only to a healthy and largely risk prevention birth, but a deep connection and inner journey for the mother and baby. I'm not being naive. I have seen the horror stories, and I remain absolutely convinced that the relationship and care for the whole person in sacred honoring of the process of pregnancy and birth is the mainstay to a healthy and satisfying outcome, setting the foundation for years to come. Where in these models do we find the place where we can practice trust, love, and honor for the process of pregnancy and birth? If we bring these into our practice and allow a woman to sleep in her comfort zone in denial from my original key point during labor, we allow the body to do its thing. What are we tending to do at this time that could interfere with labor? What do we do when the pregnant mother sits up and wants to do something? Do we say, yes, here comes transition, let's move with it, let's breathe through it? No. Too often I have heard, sit still, stop being so uncooperative, we can't get a good tracing. Okay, let's put in a catheter so that you don't have to go to the toilet. What else can be expected when you have 2 nurses in a busy labor ward? When have we looked into a laboring lady's eyes and met her with love and said, you are doing beautifully and your body is just amazing? Bringing the sacred model into birth will save lives, save money, save cesarean rates, and save staff burnout. Women will give birth to healthier babies, feel better about themselves, and becoming a parent, and babies will respond. Just try it.